Hello everyone. I'm Nafisa, and today we'll have a short session on neurocritical care and intracranial pressure monitoring. This topic is important because many ICU patients can develop increased ICP very quickly. So today, we'll keep it simple: what it is, why it matters, and what we should do. Here are today's learning objectives. We'll start with what neurocritical care is and why it matters. Then we'll review the basic anatomy and normal ICP values. After that, we'll look at the causes and signs of increased ICP, and how we treat it. Finally, we'll connect ICP with CPP and talk about key nursing principles in neurocritical care. Neurocritical care focuses on caring for patients with severe neurological conditions. Our main goal is to protect the brain and prevent secondary injury. Nurses play a key role because these patients can develop ICP changes very quickly. So continuous neurological assessment is essential, even though it's complex. Good monitoring and timely intervention are what keep these patients safe. These are the common conditions we see in neurocritical care. They include trauma, stroke, continuous seizures, different types of brain bleeding, post-surgery patients, spinal cord injuries, and severe brain infections. All of these can affect the brain's pressure, so close monitoring is essential. The main goals of neurocritical care are simple. First, we protect the brain. Second, we make sure it receives enough oxygen and blood flow. We also need to control ICP, because high pressure is one of the most common secondary injuries. And of course, we prevent complications like seizures or infections, while supporting the other organs to keep the whole body stable. Now let's move on to ICP monitoring, which is one of the most important parts of neurocritical care. The skull is a closed box, so it cannot expand. Inside it, we have three components: brain tissue, blood, and CSF. These volumes must stay balanced, otherwise the pressure goes up. Normally, ICP stays between 5 and 15 mmHg. This picture shows why ICP rises. If blood, CSF, or brain tissue increases inside the skull, the pressure goes up because the skull cannot expand. So any change in these three components can quickly raise ICP. When ICP increases, the early signs are headache, nausea, vomiting, and changes in mental status. Patients may also have vision problems or abnormal eye movements. As the pressure gets worse, you may see weakness, numbness, seizures, high blood pressure, slow heart rate, and irregular breathing, the classic signs of severe ICP elevation. ICP increases when any of the three components go up. If brain volume increases, like in trauma, ischemia, low sodium, or tumors, ICP rises. If CSF increases, such as hydrocephalus or infections, ICP also goes up. So different problems can lead to the same result: higher intracranial pressure. ICP can also rise when blood volume in the brain increases, such as with a ruptured aneurysm, high CO2 levels, venous thrombosis, or heart failure. There are also other uncommon causes, like idiopathic intracranial hypertension, skull abnormalities, or excess vitamin A or tetracycline. So overall, many different conditions can lead to increased ICP. To manage increased ICP, we start with simple steps: raise the head of the bed and drain CSF if possible. We support breathing with intubation or ventilation, and use medications to reduce swelling and prevent seizures. If all treatments fail, a decompressive craniectomy may be needed to give the brain more space. CPP tells us how much pressure is actually delivering blood to the brain. So even if the blood pressure is okay, high ICP will reduce CPP. We usually aim for a CPP of 60 to 80 mmHg, because maintaining good CPP is essential for brain oxygenation, especially in trauma and shock patients. When intracranial volume increases, ICP goes up and CPP goes down. So in trauma, swelling, or bleeding, high ICP squeezes the vessels and reduces brain blood flow. To protect the brain, we often need to raise the MAP to keep CPP adequate. And the simple formula is CPP equals MAP minus ICP. Mean arterial pressure, or MAP, is the average blood pressure during one heartbeat. We can measure it directly or calculate it. The formula is MAP equals dBp plus open bracket SBP minus dBp close bracket divided by 3. And the normal MAP is 70 to 100 millimeters of mercury. This table shows how MAP, ICP, and CPP are connected. MAP normally is 70 to 100, and CPP depends directly on MAP, so if MAP drops, CPP drops. ICP is normally 5 to 15. When ICP goes above 20, it reduces CPP and increases the risk of brain compression. CPP, which should be around 60 to 80, must stay high enough to keep brain blood flow and prevent secondary injury. Now let's move on to neurological nursing care and ICP monitoring, where we talk about what nurses actually do at the bedside. For positioning, we keep the head of the bed at about 30 degrees, and the head should stay midline and neutral to help venous drainage. We avoid anything that increases pressure, no neck flexion, no head turning, no hip bending, and try to reduce coughing or straining. For neurological monitoring, we check 3 main things. First, the GCS to assess the patient's level of consciousness. Second, the pupils, their size, symmetry, and how fast they react to light. And third, we use the RASS score to see if the patient is too agitated or too sedated. The GCS has 3 parts: eye response, verbal response, and motor response. Eye opening goes from no response to opening spontaneously. Verbal response ranges from no sound to being fully oriented. Motor response is the most important, from no movement, up to following commands. The total score helps us track changes in consciousness. Here are quick clinical tips for motor responses. If the patient localizes to pain, they move their hand toward the painful spot. This is a good sign. If they withdraw or flex away from pain, it's still a purposeful response. But abnormal flexion, decorticate posturing, means more serious brain injury. An extension to pain, decerebrate posturing, is even worse and suggests severe brain damage. Here you can see an example of GCS trending. At 9 o'clock the patient still had a total score of 15, but you can see a clear drop over time, 12 at 9:15, then 10, and finally only 6 at 9:45. The eyes, verbal, and motor scores are all decreasing. This kind of downward trend is a red flag and tells us the brain is getting worse fast. When GCS keeps dropping like this, we must report immediately and prepare for further intervention. This is the standard neurological observation chart. Every assessment includes eyes, verbal response, and motor response, and we record the best response the patient can give. We chart the GCS score over time, and any drop of 2 points or more must be reported immediately. A GCS less than 14 also needs medical review. Below the GCS, we also check arm and leg movements and note whether the patient has normal power, weakness, or abnormal posturing. Finally, we assess pupil size and reaction. Normal pupils react to light, sluggish or non-reactive pupils are a warning sign. These observations should always be done together with full vital signs. Here we use 2 main methods to monitor pain. For patients who can talk, we use the numerical rating scale, from 0 to 10. 0 means no pain, and 10 means the worst pain imaginable. For patients who cannot speak, especially sedated or intubated patients, we use the behavioral pain scale, the BPS. BPS looks at 3 things: facial expression, upper limb movement, and compliance with the ventilator. Relaxed face scores low, grimacing scores high. No movement scores low, retraction or stiff flexion scores high. If the patient fights the ventilator, the score increases. A higher total BPS means more pain, and we need to treat the pain promptly. In the ICU, our main opioid analgesics are fentanyl, morphine, and hydromorphone. Morphine works well but takes a bit longer to kick in, and it can accumulate in patients with liver problems. Hydromorphone has a similar effect but is stronger, and we need to watch out for kidney and liver dysfunction. Fentanyl works the fastest, usually within 1 to 2 minutes, and is very common in ICU because it's easy to titrate and causes fewer blood pressure changes. However, it can still accumulate, especially in organ dysfunction. Overall, we choose the opioid based on how fast we need it to work, the patient's organ function, and how stable their blood pressure is. For non-opioid analgesics, we commonly use acetaminophen, ketorolac, and ibuprofen. Acetaminophen is very safe for most patients and is good for mild pain or fever, but we avoid it in patients with liver problems. Ketorolac and ibuprofen are NSAIDs. They work well for inflammatory pain, but we must be careful because they can cause kidney injury and GI bleeding, especially in critically ill patients. We often combine non-opioids with opioids to reduce the amount of opioid needed and improve overall pain control. Now let's talk about light sedation and daily interruption, also known as a sedation vacation. The idea is simple. Instead of keeping patients deeply sedated all the time, we gradually reduce or pause sedation every day to see how awake they can be. The goals are, first, to avoid oversedation. Second, to help with early awakening and earlier extubation, especially for intubated patients. It also helps shorten ICU stay and ventilator days. We can do a more accurate neurological assessment when the patient is lighter. And finally, it reduces the total amount of sedatives and lowers the risk of complications. To measure sedation and agitation, we mainly use the RASS scale, the Richmond Agitation Sedation Scale. The scoring goes from +4 to -5. +4 means the patient is combative and may be dangerous to staff. +3 to +1 covers very agitated, and restless patients. They may pull tubes, fight the ventilator, or move a lot. 0 means the patient is alert and calm. -1 to -2 represent drowsy to light sedation. This is often our target range for ICU patients. -3 to -5 represent moderate to deep sedation, and unrousable, no response, even to pain. We also have the Riker Sedation Agitation Scale, which is similar, ranging from 1 to 7, but the concept is the same. Higher numbers mean agitation, lower numbers mean deeper sedation. When a patient becomes agitated, we follow a simple step-by-step approach. First, we look for reversible causes: pain, hypoxia, urinary retention, constipation, or equipment problems. Fix what we can fix. Next, we provide non-pharmacologic treatment, reorientation, calming the environment, correcting sleep cycle, family presence if appropriate. If the patient is still agitated, we move to analgesics or sedatives, depending on the cause. For analgesics, we check hemodynamics. If unstable, we choose drugs like fentanyl, remifentanil, or ketamine. If stable, we can use morphine. For sedation, we use midazolam, or propofol or dexmedetomidine for continuous infusion. If the patient has delirium, we target that specifically using dexmedetomidine or haloperidol when needed. This stepwise approach helps us safely manage agitation in ICU patients. Next, let's talk about basic nursing care. Vital signs monitoring. We always check blood pressure, heart rate, respiratory rate, temperature, and oxygen saturation. Any sudden change may indicate a neurological problem. Medication administration. Give medications carefully as prescribed. Also check the IV site for infiltration or phlebitis, signs like swelling, redness, or pain. Sensory and motor control. We watch for paresthesia, weakness, or hemiplegia. If we see new weakness or numbness, we need to report it immediately because it may mean the neurological condition is getting worse. Now let's talk about fluid and water balance. For patients with brain injury, we try to keep normal fluid volume by using isotonic fluids, like 0.9% normal saline. We avoid hypotonic fluids, because they can make the brain swell more. We may give diuretics, such as hypertonic saline, 3% or 7.5%, or mannitol 20%, to help reduce brain swelling. We also insert a urinary catheter to check urine output accurately. And finally, we record all fluid intake and output very carefully. Next, let's talk about cerebral edema. Our main goal is to follow the doctor's orders to help reduce brain swelling. We also watch the patient's electrolytes very closely. If electrolytes go out of balance, the patient may show confusion or arrhythmias, so we check for these signs. And finally, we give electrolyte supplements as prescribed to keep levels stable. Now let's look at the risk of ineffective cerebral tissue perfusion. First, acid-base control. We monitor the ABG, especially for patients on a ventilator, because abnormal gases can affect brain perfusion. Next is seizure control. We give anti-epileptic medications as prescribed, and we carefully observe and document any seizure activity. Lastly, shock control. We give vasoactive medications to maintain blood flow, and we closely monitor kidney function, including urine output and creatinine levels. Now let's look at airway and gastrointestinal care. First, airway aspiration. Always check that the probe or tube is in the correct position before suctioning. Avoid frequent suctioning, only suction when necessary. Keep each suction pass less than 10 seconds. Also check and record the gastric residual volume. Next is artificial airway management. We perform lung auscultation to assess breath sounds, and we provide regular oral care to reduce infection risk. Lastly, vomiting control. We give antiemetic medications as ordered, and we monitor and document any episodes of nausea or vomiting. Now let's talk about respiratory management. First, airway control. We give bronchodilators as ordered to keep the airway open. Next, oxygen therapy. We provide supplemental oxygen according to the doctor's prescription, and we closely monitor the patient's SpO2 and their breathing pattern. Now let's look at skin integrity and mobility care. First, pressure control. We can use air mattresses, pyramidal mattresses, or pneumatic mattresses to reduce pressure on the patient's body. Next, skin care. We apply moisturizers and essential fatty acids to keep the skin hydrated and healthy. For wound care, we perform dressing changes and use protective coverings when needed. Next, let's talk about positioning and mobility. First, positioning. We need to reposition the patient regularly to prevent pressure injuries. If possible, we can also sit the patient in a chair to improve circulation and comfort. For pressure injury prevention, we assess the risk level using the Braden scale. Finally, for exercise therapy, we encourage and assist the patient with mobility and walking, as tolerated, to maintain muscle strength and circulation. Now let's talk about infection prevention in neurocritical patients. First, hand hygiene. Always clean your hands before and after touching the patient. Next, use PPE as required, gloves, masks, and gowns. For any invasive procedure, we must keep strict aseptic technique. We also need to make sure the environment is clean, with proper disinfection and waste disposal. And lastly, use dedicated clothing and equipment, and avoid wearing jewelry in high-risk areas. Now let's look at neurospecific infection prevention measures. First, we try to minimize and monitor the use and duration of invasive devices like ICP monitors or EVDS. We must keep all systems closed and sterile, and handle them very carefully. For long-term drainage, we can use antimicrobial catheters, such as silver-impregnated ones. We also follow neurosurgical protocols, for example, hair clipping instead of shaving, gentle tissue handling, and using double gloves. To prevent VAP, keep the head of bed above 30 degrees, provide oral care with chlorhexidine, minimize sedation, and avoid unnecessary intubation. Use prophylactic antibiotics only for high-risk neurosurgical patients. And lastly, we try to limit CSF sampling to reduce the risk of infection. Thank you all for your attention. Neurocritical care is complex, but with good monitoring, teamwork, and consistent nursing practice, we can really protect our patients from secondary injury. If you have any questions or want to practice any part again, feel free to ask me anytime. Thank you.